Bismillahirrahmanirrahim. Quote of the day: remember, when you forgive, you heal, and when you let go, you grow. Today, the topic of my presentation is maternal mortality under kind supervision of Professor Dr. Saira Afzal. Assalamu alaikum. Learning outline of my presentation is introduction, global burden of maternal mortality, direct and indirect of death, measurements of maternal mortality, causes of maternal mortality, how it is prevented, action for reduction in maternal mortality rates, and at the end there is recent advances. At the end of this presentation, participants will be able to describe the global burden, direct and indirect of death causes, measurements of maternal mortality, causes of maternal mortality, prevention, and action for reduction in maternal mortality. Every day, approximately 830 women die from preventable cause related to pregnancy and childbirth. 99% of all maternal deaths occurring in the developing countries. Maternal mortality is higher in women who are living in rural areas and poorer communities. Young adolescents face a higher risk of complication. Skill care before, during, and after childbirth can save many lives of the women and newborn babies. Between 1990 and 2015, maternal mortality worldwide dropped by about 44%. Between 2016 and 2030, as part of SDGs, the target to reduce the maternal mortality ratio in Pakistan is 70 per 1 lakh live birth. When the Millennium Development Goal is proposed, its fifth target is reduce maternal mortality ratio by 3/4 between 1990 and 2015, and this target is achieved because the MMR is decreased in these years. Almost 85% women will deliver normally. 10 to 15% women will develop complication, and 3 to 5% women will need surgical intervention. 20 to 25% death occurring during pregnancy. Almost 40 to 50% death occur during labor and delivery, and 25 to 40% deaths occur after childbirth, and most of death occurring during first 7 days. Now we discuss the global burden. 5,29,000 deaths per year, or 40 deaths 1 lakh live birth. 1 death per minute, and 1% in developing countries, and its range is from 24 to 830 per 1 lakh live birth. 19 to 20 countries with high MMR lie in the sub-Sahara Africa. There is a lifetime risk for a woman, risk of losing a neonate, and the risk of dying due to maternal cause. In Africa, the ratio of risk of losing a neonate is 1 in 5. In Asia, this is 1 in 11. In Latin America, this ratio is 1 in 21. And in developed countries, this ratio is 1 in 125. And risk of dying due to maternal cause in Africa, this ratio is 1 in 16. In Asia, this is 1 in 132. In Latin America, the ratio is 1 in 188. And in developed countries, this ratio is 1 in 2976. This is the maternal mortality ratio in the Pakistan, and there are different figures from Punjab, Sindh, Khyber Pakhtunkhwa, Balochistan, and Pakistan, Azad Jammu Kashmir, and Gilgit-Baltistan. The upper value showing the maternal mortality rate in the previous years, and the blue dots showing the current figure, and the lower figure is achieved till 2030. Like in 1990 to 91, MMR in Pakistan was 234 per 1,000 live birth. It has reduced to almost 186 and it is expected to drop to 138 by year 2030. And similarly, all this data is shown. Maternal mortality, death of a woman who is pregnant or within 42 days of termination of pregnancy, irrespective of the site or duration of pregnancy, from any cause related to or aggravated by the pregnancy or its management. There are two categories: direct ops death and indirect ops death. The death resulting from ops complication of the pregnant state, like pregnancy, labor, and puerperium, from intervention, omission, or incorrect treatment, or from a chain of events resulting from any of the above, or called direct ops death. And indirect ops death, this resulting from previous existing disease or disease that developed during pregnancy and that was not due to direct ops cause but was aggravated by the physiological effect of pregnancy. What is late maternal death? Late maternal is a death of a woman from direct or indirect ops causes more than 42 days but less than 1 year after termination of pregnancy. Pregnancy related death, defined as the death of a woman while pregnant or within 40 days of termination of pregnancy, irrespective of the cause of death. To facilitate the identification of maternal death in circumstances in which cause of death attribution is inadequate, ICD-10 introduced a new category, that of pregnancy-related death. How we measure the maternal mortality? There are three main measures of maternal mortality: maternal mortality ratio, maternal mortality rate, and the lifetime risk of maternal death. What is maternal mortality ratio? This represents the risk associated with each pregnancy. It is calculated as the number of maternal deaths during a given year per 1000 live births during the same period. This is usually referred to as rate, though it is a ratio. The appropriate denominator for the maternal mortality ratio would be the total number of pregnancies, live birth, fetal death or stillbirth, induced and spontaneous abortion, ectopic and molar pregnancy. However, this figure is seldom available and thus number of live birth is used as the denominator. In countries where maternal mortality is high, denominator used is per 1000 live birth, but as this indicator is reduced with better services, the denominator used is per 1000 live births to avoid figure in decimals. Why the maternal mortality is happening? Because of three delays model: delay in seeking care, delay in transport to appropriate health facility, and delay in the provision of adequate care uh, during the delivery. 20% cause of maternal mortality is indirect, and the 80% is the direct cause. And the four major causes which contribute the maternal mortality are hemorrhages, infection, eclampsia, and the obstructed labor. Why the maternal mortality is happen? There are some underlying factors like socioeconomic status and the nutritional status of the pregnant female. Children who lost their mother are more likely to die within 2 years of maternal death, 10 times the chance of death for the neonate, and 7 times the chance of death or infant older than 1 month. 3 times the chance is increased for children 1 to 5 years. Enrollment in school or younger children is delayed, and older children often leave school to support their families because of maternal deaths. There are some social issues which contribute the maternal mortality, like early marriages, gender discrimination, illiteracy, desire for selective sex of a child, mostly in over setup, preferred male child, domestic violence, and in the economic issue, there is a lack of money, lack of timely transport and communication, delay in taking decision to shift the patient or refer the patient, improper dietary habits, which are followed by the females during pregnancy. Uh, Medical issues, there are no proper checkup, antenatal care, and there is a lack of emergency ops care, lack of blood and blood products, lack of essential drugs in different setups which dealing with emergency like BHUs, junior staff dealing with high risk cases without supervision, and delay in diagnosis or the wrong diagnosis. How we prevent the maternal mortality? We prevent the maternal mortality with the help of health education, like what is the suitable age for the marriage, utilization of rural care health services, awareness of antenatal care, nutritional education, importance of immunization, and the spacing between the childbirths. We also prevent the maternal mortalities by better in the health delivery infrastructure, provision of rural care health services at remote rural areas and urban slums, improved staffing, facilities for essential and emergency ops care, and training of traditional birth attendants. By the safe abortion services and health education about the contraception. Healthcare delivery, emergency management of eclampsia, third stage complication at primary healthcare level, and flying squad services. Adoption of our small family norms with the help of family planning. Prevention of anemia is very much important, and then we also reduce the maternal mortality rate. And for the prevention of anemia, there is a concept of 100 tablets of iron at puberty, at the time of marriage, during pregnancy, and during lactation. And in the non-health strategies, we reduce the maternal mortality by poverty eradication, improvement of literacy, women empowerment measures, improved communication, and the improved transport facilities. And there is action for a safe motherhood, legislative and policy actions, involvement of societies and community, and the major involvement of the health sector. National, regional, and district safe motherhood communities, health facilities, and community committees, raising awareness on danger sign, provision of for clean deliveries, trained birth attendants in the remote and inaccessible areas, improving maternal nutrition, addressing certain disease like malaria, TB, HIV/AIDS, hepatitis, preventing unwanted births, and reducing unsafe abortions. And in the health sector facilities, we better over health sector by the establish the antenatal clinics, emergency obstetric care with the help of skilled birth attendants, postnatal care, abortion services, and the first referral units are built which deal the emergency ops care, iron, folic acid, and injection of tetanus toxoid, and provision of the family planning services. What is first level maternal care? Such care has three functions. Birth take place in the best of circumstances, resolve complication as they arise, to respond to life-threatening emergencies, organized midwife-led birthing centers combining cultural proximity in a non-medicalized setting with professional skill care, necessary equipment, and the potential for emergency evacuation. Backup care is very much important, ideally provided in a hospital where doctors, specialists, skilled journal practitioners, or mid-level technicians with the appropriate skill linked with the first level care, 24 hours availability, emergency and non-emergency condition, both first level services and backup care to rolled out simultaneously. Essential ops care, registration of pregnancy in the first 12 to 6 weeks is very much necessary. at least 3 antenatal checkup, assistance during delivery with the help of skilled birth attendants, and at least 3 postnatal checkups are also very much necessary. Microbirth plan. What is microbirth plan? Inform the mother and the family about 4 I's, namely inform dates of 3 antenatal checkup, tetanus toxoid injection, and ensure that these all are provided. Identify the health center for all referrals. Identify the place of delivery and inform the expected date of delivery. There are some challenges which are faced. Establishing database on maternal mortality, high risk pregnancy behavior, too early and too many, too close, urban rural division, poor rate of institutional deliveries, lack of skill care at birth, poor implementation of program, and the lack of women empowerment. There are 10 actions which are taken for the safe motherhood, advance safe motherhood through human rights, empower women. Safe motherhood is a vital economic and social investment, delay marriage and the first birth. Every pregnancy faces risk, ensure skill attendance at delivery, improve access to quality reproductive health services, prevent unwanted pregnancy and address unsafe abortion, measures progress, and the power of partnership. Now it's time for the recent updates. What is the UNICEF response for the reduction in maternal mortality? All babies and mothers are entitled to affordable, high quality healthcare before, during, and after pregnancy. To make services accessible to all, UNICEF and partner adopted the Every Newborn Action Plan, a global roadmap to reduce newborn mortality. As a part of this commitment, UNICEF support countries to provide essential package of high quality maternal and newborn services such as home visit, kangaroo care, skin to skin contact between parents and babies to increase their chance of survival. UNICEF also work with partners to eliminate maternal and newborn tetanus, collect information on adolescent pregnancy, and train healthcare workers to address the specific needs of adolescent mothers. What is the WHO role in the reduction of maternal mortality? Improving maternal health is one of WHO's key priority. Works to contribute reduction of maternal mortality by increasing research evidence, providing evidence-based clinical and pragmatic guidance, setting global standard, and providing technical support to member states on developing and implementing effective policy and program. As defining in the Ending Preventable Maternal Mortality Strategy, WHO is working with partners in supporting countries toward addressing inequalities in access to and quality of reproductive maternal and newborn healthcare services. In 4 aspects, the WHO have a very much response in ensuring universal health coverage for comprehensive reproductive, maternal, and newborn health care. They addressing all causes of maternal mortality, reproductive and maternal morbidities, and related disabilities. Strengthen the health system to collect high quality data in order to respond the needs and priorities of women and girls, ensuring accountability in order to improve the quality of care and equity. This is one of the article which main heading is correlation of maternal mortality in developing countries and ecological study in 82 countries. And in this article, maternal mortality is correlated with multiple socioeconomic factors, healthcare system associated factor, disease burden, and their complex interaction. Therefore, policy and programs targeted to improve maternal health and reduce maternal death should consider population dynamics, socioeconomic influence, and health system factors that impose a major risk on mothers. This is the start of US and different European countries. And in the US, the maternal mortality rate is high. And why? And this is the article in which they discuss why the maternal mortality rates are high in the United States and what are they did to reduce it. Maternal mortality and severe maternal morbidity are critical health issue in the United States with unacceptability high rates, racial, ethnic, and geographic disparities. This review briefly discuss initiative to reduce maternal mortality and severe maternal morbidity in the areas with the help of data and surveillance, clinical workforce training, patient education, development of telehealth sector, comprehensive models and strategies, clinical guidelines, protocol, and bundles. This is the some stats which show the maternal death ratio in the South Asian countries, and in the WHO says that maternal mortality trends estimate the South Asia accounts for almost 57,000 maternal death, and the Pakistan, India has very much high rate of maternal mortality deaths, and in the Pakistan, the prevalence of maternal mortality is 14.47. Sri Lanka is one of the country in which the maternal mortality is very much low, almost 0.21%. What is the current scenario of maternal health in the rural areas of Pakistan? Pakistan ranked fifth in the world according to population. Pakistan is an agriculture-based economy, and recent stat shows that 64% of Pakistani population live in rural areas. According to the most recent report on the nationwide maternal mortality survey in Pakistan, MMR is 186. The report also indicates a considerably increased incidence of maternal death in the rural areas of Pakistan. MMR for urban areas is 158, while on the other hand, this is 199, and the difference between rural and urban areas almost 41 deaths per 1,000 live birth. This is one of the case report. Childbirth is a miracle of life and it should not become a nightmare of death. Now, there is an MCQ session. A lady presented with puerperal sepsis and lost life in a government sector hospital due to late presentation. High maternal mortality is a grave issue in developing countries. In Pakistan, MMR per 1000 live birth is 350, 290, 300, 320, or 186. The correct answer is 186. A lady presented with heavy vaginal bleed on third postpartum day, delay in presentation, and inability to arrange blood resulted in a loss of her life. One of the major direct cause of maternal mortality in Pakistan is eclampsia, preeclampsia, hemorrhages, sepsis, abortion, or the ruptured uterus.
B.
B is the right answer, hemorrhages. A 35 years old lady, mother of five children, presented in emergency with loss of consciousness and fits on the second postpartum day and could not survive. In Pakistan, maximum maternal mortality is associated with following factors: age of mother less than 18 years, primigravida, grand multipara, poor pregnancy, poor previous pregnancy outcome, or delay referral.
E.
E is the right answer, delay referral. A lady during delivery at home by untrained dye developed complication before delivery. Dye did not inform the family of the family of the situation until condition becomes serious. Even knowing the gravity of situation, further delay in decision to take her to hospital and arrangement of transport took place. Major reason for high maternal mortality and morbidity in Pakistan is delay in decision by DAI, delay in decision by family, delay in transport, delay in referral system, delay in appropriate treatment.
Beta.
Alpha, delay in decision by DAI. In city of mid-year a population of 1 lakh, there were 2500 live birth during year. In same year 11 women die due to following reason: postpartum hemorrhage 5, toxemia of pregnancy 2, abortion 1, obstructed labor 2, and the electrocution 1. Calculate the maternal mortality rate. Any guess?
Alpha.
Alpha is the right answer, 4 per thousand live birth. Because the total number of maternal death is 11, 1 is the cause of electrocution and 10 women are died due to the pregnancy related complication, and divided by 25,000 live birth and multiply by 1000, and the answer is 4 per thousand live birth. A lady presented with obstructed labor after a trial of delivery by a trained die in a remote area of sin due to timely referral and timely intervention in specialized care facility. Life of both mother and baby was saved. The percentage of home deliveries under skilled birth attendants are 65%, 75%, 85%, 95%, or 97%.
Alpha.
C, 85%. During puerperium, most difficult complication to manage is puerperal sepsis, postpartum hemorrhage, rupture of uterus, genital fistula, puerperal psychosis.
B.
Yes,
E.
genital fistula, D is the right answer. In a given area, 2 women died of eclampsia and 3 women died of postpartum hemorrhage. Total number of reported live birth 1000. Calculate the maternal mortality ratio. 5 per thousand live birth, 4 per thousand, 6 per thousand, 8 per thousand, or 10 per thousand live birth. A is the right answer, 5 per thousand live birth, because the woman died due to pregnancy related complication are 5. 5 divided by 1000 multiplied by 1000, and the answer is 5 per thousand live birth. MMR is highest in sub-Sahara Africa and South Asia. In which region there is MMR is lowest? Pakistan, India, Bangladesh, Sri Lanka, Bhutan.
E.
D, Sri Lanka is the right answer. A primi gravida during her second antenatal visit to tertiary tehsil headquarters complained of recurrent headache, blurring of vision, and faulty urine. Simplest way to determine that her pregnancy is high risk is urine for albumin, record BP, do pelvic measurements, record weight, estimate hemoglobin. A is the right answer, urine for albumin, because this is the case of preeclampsia. This is the key of my MCQs, and thank you.